A very warm welcome to everybody to this evening's webinar on understanding COVID vaccines, the impact on pregnancy and beyond. So this evening we'll be talking about the impact of the COVID vaccines on conception, pregnancy, breastfeeding, and the impact of the vaccine on your baby. I'm delighted to have two excellent co-speakers tonight. Professor Bill Rawlinson is an infectious disease specialist who's an attending medical officer here at the Sydney Adventist Hospital. Professor Rawlinson is Professor of Virology at the University of New South Wales. He's a world expert on viral infections in pregnancy, particularly cytomegalovirus, and I'm delighted Bill's going to talk to us about COVID vaccines. I'd also like to welcome Dr. Giri Pravala. Giri is an experienced obstetrician and gynecologist, and really excited to hear what Giri has to say about the latest data on the COVID vaccines, particularly affecting pregnant women and breastfeeding. Just some housekeeping, if we could please. Your microphone and video will be turned off by default, but questions may be asked at any time via the Q&A module, which is found down on the bottom of your screen on the right-hand side. Please don't ask any questions in the chat window. We will do our best to address every question, but if we don't answer your question during the session, we will respond to you after the event. If you could please be sure that you're in a private and secure location. This is for registered attendees only and shouldn't be shared with any other third parties. Please note the webinar is also being recorded, and some of the elements of this session may be used in the future for other purposes by the Sydney Adventist Hospital Group. All efforts, of course, will be made to protect participant identity, and if you do have concerns about this, please speak to the event coordinator. Ben is on the line. I'm going to talk just generally about vaccination and the SAN and just do a brief introduction to the COVID vaccines. My name's Jeffrey Hercus. I'm actually a neurologist, but I'm the Director of Research at the SAN, and I'm very excited to talk with you about some of these vaccines. As you know, currently in Australia, the two vaccines that are being used widely are the AstraZeneca vaccine and the Pfizer vaccine. Vaccines can be made through a variety of methods. The conventional methods on the left here have been used for many, many years, particularly with the influenza vaccines. Some of the other conventional methods use protein subunits, for example, with hepatitis B that many of us would have had before we travel overseas. These vaccines require what are called adjuvants, which are additions to the vaccine, and sometimes they can cause problems with allergies or other unwanted side effects. What's been interesting about the COVID vaccines is we've used some novel methods to develop the vaccines. The novel methods are either a viral vector, and these are based on some of the newer vaccines that have been particularly researched in some of these terrible diseases in Africa, Ebola and MERS, for example, the recent outbreak in MERS. So these vaccines were already being developed prior to COVID. The new approach is with the RNA vaccines, and there's been no previous human vaccine using RNA or DNA technology. And we will talk about that because there are some fears and misapprehensions in the community that are not based on evidence about some of these vaccines. Just to briefly remind you of the types of vaccines we have currently available for COVID. The older style vaccines using the old techniques are those which the Chinese companies have developed, and they're listed there, Sinovac, for example. Protein subunit vaccines are available in some places in the world, not yet in Australia, but Novavax would be the premium vaccine for that. Of the viral vector vaccines, we have two currently approved in Australia. The AstraZeneca vaccine, of course, which is the one we know about. Australia has also approved the Janssen vaccine. Now, the Janssen vaccine is also the Johnson & Johnson vaccine, which is widely used in America. So they're interchangeable. It's very unlikely we'll roll out the Janssen vaccine in Australia, even though it has been approved, mainly because of supply issues. And the government, I don't believe, has actually signed a contract. Probably that's reasonable because if the AstraZeneca, as you know, has run into a few little issues, and Janssen and the Johnson & Johnson one have the same issues. And so it's probably not unreasonable not to roll that one out. The other two vaccines we know about here, or the one that's very well known in Australia now, is the Pfizer vaccine, and it's an RNA vaccine. And Australia, the TGA, has just recently approved Moderna vaccine about 3 weeks ago. It hasn't been rolled out yet, but certainly the vaccine has been what we call batch tested in Melbourne, so that once the supplies are available, we will be able to roll out the Moderna vaccine. And it appears to be just as effective as the Pfizer, and particularly for pregnant women or women trying to conceive, it will be, and also, I'm sure we'll hear later tonight, an acceptable vaccine for COVID-19 protection. Who gets vaccinated? Well, as you know, the World Health Organization, a very august body, has put out a lot of talking points about who should be vaccinated. And there's a range of issues that are very important, but which seem in many ways to have gone by the wayside with the global pandemic. The principles are meant to be looking at all human well-being, equal respect for all humans, regardless of where they are, global equity, national equity, reciprocity, and legitimacy. And all of those kind of wonderful phrases, of course, when you're faced with a global pandemic, tend to be a little bit put to the side. You may remember earlier this year we had the phased rollout of vaccines, and we all looked carefully as to whether we'd be phase A, 1B, 2A or 2B. Essentially, again, as you know, in Sydney, this has very much changed because of the most recent Delta outbreak. And so that this phased rollout is not quite as phased as it should be. We're seeing special groups getting special consideration, and that's not at all unreasonable given the Delta outbreak. And so again, it's worthwhile just remembering that things are changing very rapidly, particularly in Sydney with the Delta outbreak. Why bother to get vaccinated at all? Well, really, I just want you to look at this column for the Pfizer vaccine effectiveness. If you've had 2 doses of Pfizer, what does it give you? Well, it gives you about 85 to 90% protection against symptomatic disease. It's about 95% protection against going to hospital. And it's up to 99% protection against dying. Can you still get infected after the Pfizer vaccine? Yes, you can, but you've got about a 70 to 90% protection. But if you do get infected, you can still transmit the virus. You transmit it less than if you weren't vaccinated, but there is still a transmission rate. And that's why all of the social isolating, mask wearing, etc., will still apply even after you've been vaccinated if there's a lot of COVID around. The data for the AstraZeneca is very similar to that for Pfizer. And I apologise, I don't have the longer term data on this slide, but it's similar, perhaps a tiny bit lower than that for the Pfizer, but still a very effective vaccine for people, particularly in my age group, that is the elderly. Why bother to get vaccinated at all? Well, it protects against the infection. It protects against severe disease and death. It does reduce your anxiety. After the second dose, most of my family felt a little bit more relaxed. It protects close contact, particularly the elderly and the immunosuppressed in your family. And there's this term, as you know, of protecting the community with enough vaccination to give us some level of overall protection. And the benefits are the greatest in older people. There are always side effects. There are always risks of any treatment, and the risks of the vaccines are listed there. The risks are small, but we might discuss them in the Q&A a little bit later if anyone is interested. COVID has now been around long enough that even are jokes about it. So in retrospect, in 2015, not a single person got the answer right when they were interviewed, where do you see yourself 5 years from now? And I particularly like this one on the right where it says it's a vintage picture, an old tradition of people eating cake after someone blows air from their mouth onto it, about 2019, BC, before coronavirus. What about the Sydney Adventist Hospital and vaccination? The Sydney Adventist Hospital has always supported vaccination. It's always supported evidence-based medicine, and it's always supported preventative health. One of the tenets of the hospital is healthy eating, healthy living, and preventing illness. In many ways, the decision as to whether to get vaccinated or not as a healthcare worker has been taken out of the hands of individual hospitals, or indeed even individual workers. You've all heard of the public health orders, and this is a public health order referring to health workers. It's not a particularly glamorous document, but the bit that's important is here, point 4. The minister directs that a healthcare worker must not do work as a healthcare worker unless, if the work is done on or after September the 30th, but before the 30th of November, you've had 1 dose of vaccine, or after the 30th of November 2021, you've received your 2 doses of vaccine. There are some exemptions, possibly for medical reasons, but otherwise it's a blanket order that everyone who's a healthcare worker, and that ranges from pretty well everyone in the hospital, will need to be vaccinated. Ladies and gentlemen, thank you very much for listening. It's a great pleasure to hand over now to Bill Rawlinson. Bill has a great knowledge of viruses and vaccines. And Bill, thank you so much for telling us about the COVID vaccine and testing.
Thanks, Jeff, for those comments. And look, thank you very much for coming and listening to me talk about diagnosis, some of the current things with SARS-CoV-2 and COVID-19, and talking a little bit about vaccines, particularly in relation to disease prevention, because I think it's very important to say up front that vaccines are just one aspect of preventing COVID-19. I like this slide. One of the things that we've seen, of course, is a number of social distancing and other jokes around COVID-19 to keep us all sane, really. And this is a remake of the cover of Abbey Road by the Beatles. Not only unusual because Paul McCartney has no shoes on his feet, but also because he's smoking, and clearly they're now social distancing. What I would like to acknowledge first is that the work that we do here, and I'm the director of the current largest testing public health laboratory in the state, here at the Serology Virology Division. But of course, the real work is done by the scientists. And on the left of your screen is our research group, who are able to do a lot of work around SARS-CoV-2, in particular molecular virology. And on the right are some of our diagnostic lab. And the important aspect that we've seen is, of course, that these two labs now work together very closely, particularly for COVID-19. Again, I like this quote from Mohandas Gandhi, that actions express priorities. And what we've seen, of course, is that as the pandemic has changed, so have our priorities changed. And as we've learned more about SARS-CoV-2, the virus, we've been able to, I guess, act in ways that prevent spread, things like masks, hand washing. But of course, with vaccines become available, vaccination particularly has been a focus. And of course, also, as we have seen vaccination of large numbers of the adult population, other groups such as pregnant women, such as children, are becoming more the focus of our vaccine and prevention methods. It's important to think about why we're in a pandemic, and although that may be obvious, it is very important that a pandemic is basically just large numbers of infected people, and things like population immunity, genomics, severity of disease, number of people who've been vaccinated have nothing to do with that definition. We do see pandemics with multiple seasonal epidemics of things like influenza, but of course we don't think of them in the same way, because this is a virus, influenza, that we've been living with for a long time. It has vaccines available, it has therapies available, and in going forward, it's very likely that we will see SARS-CoV-2 in a similar way as a yearly vaccination, as something we have treatments for, particularly at the moment monoclonal antibodies, but in the future probably antivirals, and something that we have a need to live with. The other thing is genomics has become a bit of a focus in many ways, and we talk about the Delta strain now. We used to talk about that as B.1.617.2, but this is simply a lineage. It's a type of virus that's descended from previous SARS-CoV-2 viruses over the last 18 months or so. And it's important to think about this, because we will see further emergence of lineages, and remembering that as we see them, we link clinical outcomes with them. And in the case of the Delta strain, of course, larger amounts of spread, larger numbers of cases, more people in ICU are linked to this genomic concept of a lineage. SARS-CoV-2 is very close to SARS-CoV, what was called SARS coronavirus. It also very closely resembles some viruses found in bats. And so, in a sense, we've been seeing the virus that we're seeing currently for almost 20 years, but the big difference is that we saw introduction globally and the occurrence of a pandemic, whereas with SARS coronavirus 1 in 2003, we didn't see the same level of spread. Genomically, the viruses that we're seeing now are very closely related to bat viruses. And why I say viruses is because, of course, we're seeing different lineages. And so, in a sense, they're all SARS-CoV-2, but they do have some variation. It's very likely this emerged from a virus that was present in bats and either spread directly to humans or through animals. There's a lot of politics around this discussion. I won't go into that. But it is interesting if you look at a virus like OC43, showed in the middle of your screen. This was a coronavirus that in 1890s most likely caused a pandemic, came through cows, infected humans, and is now basically a virus we see every winter and something that causes the common cold. What is very evident from spread is that the initial spread was out of Wuhan in Hebei province in China. Whether it arose there or not, again, has become politicised and is probably not possible to know. It is very evident from publications at that time coming out of China that the initial viruses were seen very closely linked to a wet market, an animal market in Wuhan in Hebei province in China. And of course, what happened subsequently is spread globally. We have also seen outbreaks initially with things like cruise ships were quite famous and well publicised. Now we're seeing spread within local groups, within, for example, people who are working in close proximity within industries, within wards in some cases. And so with the Delta strain that we're seeing currently, we're seeing the same kind of spread locally, but in much larger numbers. I've just provided the definition of SARS-CoV-2 shown here. It's important to remember that the definition is very dependent upon testing. And most testing, of course, is done using a nucleic acid test, such as PCR, which is specific for SARS-CoV-2. There was a lot of discussion about how accurate this was, why people continue to have positivity after they apparently became clinically well. And the lack of relationship later in the illness between positivity on the nucleic acid test and virus culture. Of course, now there's a lot of discussion about rapid antigen tests. Again, I won't discuss that in detail except to say they have a much lower sensitivity than nucleic acid tests, and specific PCRs predominantly remain the standard of care for diagnosis of SARS-CoV-2. In terms of numbers, this is the numbers from last week, although these, of course, have increased subsequently. And just a couple of points. It's very evident that the outbreak we're seeing now is following similar kinds of increase to the outbreak we saw last year. The interesting thing is the slope is much more rapid, and the number of cases has gone up very rapidly. But interestingly, the number of deaths have been not increasing to the same extent. The question is whether that's going to be delayed effect, and we'll see that over the next 2 to 4 weeks, or in fact whether there is a lower death rate with Delta strain, which of course would be something that you'd wish for. If you just do the crude death rates, then it has gone down. But as I say, it may be too early in the current increase to see those that level of mortality. The R0 number, that is the number of individuals infected by an infected case, has gone up from around 2.5 with the original strains of SARS-CoV-2 from last year to around twice that, somewhere between 5 and 6. And that really accounts for what we're seeing at a clinical level. That is, an individual is infecting a lot more other people, and the individual is also probably asymptomatically spreading for a couple of days prior to symptoms in larger numbers than we saw previously, and possibly for a longer period of time, although that still remains to be seen. Of course, alongside what we've seen have been much larger numbers of tests being performed, and particularly in this outbreak, the number of tests have gone up many-fold, around about 4 or 5-fold on previous test rates. The positive test rate has remained low, although interestingly over the last week in our laboratory, which is reflected also in others, the positivity rate has gone up quite considerably as there have been a number of outbreaks. I won't go into detail about diagnosis. All laboratories have their own protocols, and I'll give you our protocol, which is roughly similar to most reference laboratory methods for testing. We started testing a couple of days after the announcement was made. We had artificial templates, so we had tests in place prior to the first case of SARS-CoV-2 being diagnosed. We used an in-house a polymerase chain reaction, or PCR, which is based around a couple of common genes targets which are known, E, N and ORF1b. There are now a number of other targets used in assays, and some assays use somewhere between 3 and 8 targets. We started with an in-house assay which was kindly shared with us by Hong Kong University. There were US Centers for Disease Control as well as WHO protocols. But now, essentially, there are a number of automated platforms. They are all very good. We happen to use a couple of platforms shown there. They are good platforms, but as I mentioned, there are a number of other ones. We use a genetic signatures one, which is an Australian product, and there are a small number of ones, but the majority of commercial assays actually come from overseas. Very early on, with reagent shortages, we started pooling. We do pools of 4, and that simply means 4 patients put into a single reaction. We've verified that that is no less sensitive than testing individual patients. Some laboratories use pools of 8 and some higher. This reduces reagent use. It also means that the workflow can be much faster, and when you're doing several thousand tests a day, and where that often goes up, it is very important that your workflow remains relevant so that appropriate public health can be maintained. And I just remind you that in some cases in Western New South Wales, with the latest outbreak, there have been delays of up to 5 or 6 days, not because there's any problem in the laboratory, but simply because of the large numbers. And so anything that can improve that workflow, anything that can give you a rapid test, such as using rapid molecular tests, and a couple that we use are shown there. There are others. Anything like that can reduce the time from swabbing to providing a report back to the public health unit, to the clinicians caring for that patient, so that they can either de-isolate or continue isolating and treat appropriately. Anything that reduces that is clearly very important. As I mentioned, there have been reagent shortages. They have happened on and off. Most recently, there's been one with one of the platforms we use for rapid testing, although that's now improving. There's also reduced mean time between failures because we're operating machines typically 24 hours a day. As you might imagine, staff who 12 months ago felt relieved that the worst was over are now quite stressed. There are a lot of problems with people at home, the need for lockdowns. And so it's very important that those are attended to, not only in our patients but also in our staff. And finally, we have a plan whereby we maintain 2 teams, the white team, the blue team. That's simply based upon the colour of their coats that they wear in the laboratory. And what that means is that we plan for the risk of infection of laboratory scientists. Of course, although we're predominantly doing PCR at the moment, there are a number of other emerging platforms, and we work on a number of multi-detection platforms which use capture to detect not only SARS-CoV-2 but other viruses and agents at the same time. So just in summary, there's been very rapid introduction of commercial platforms, of new technology. We had very early quality assurance programs. The earliest program in the world was actually run in Australia through the RCPA QAP, through the biosecurity QAP that I chair. There's been a lot of data sharing, and there's been a lot of governance through things like the CDNA and Public Health Laboratory Network, so Commonwealth instrumentalities that basically allow sharing of information. The other thing that has happened is genomics has really come to the fore, and so all SARS-CoV-2 isolates in New South Wales and in fact in Australia are now sequenced using whole genome sequencing. There's been very rapid use of that Australia-wide, but also globally. And in fact, the demand for sequencing has gone from an expectation of having a sequence in a few days to having it the same day, based upon some work that in fact we did, looking at a novel platform and looking at how to use that in order to get an answer of the genomics of that particular virus within 8 hours. And in fact, with the Delta strain shown here as B.1.617.2, it's really only accelerated the demand for such testing. And so these are some examples of some papers. There have been papers from all around the world. Some of the best sequencing work has been done in the UK, but also in really every developed country. In many developing countries, there have been sequences available in order to look at spread of viruses. I mentioned the term lineage, and the reason that that's become so significant is that we are seeing some lineages, such as the Delta strain, which have increased spread and have different characteristics. And this is an unpublished figure from us shown here, where the red basically shows mutations in the virus, particularly in this B.1.617.2 Delta strain lineage, which are associated possibly with increased fitness and therefore increased spread between individuals. So there's a complex evolution of SARS-CoV-2 going on. It almost certainly started in bats. That's the current most plausible working hypothesis. It may have been modulated through an animal, possibly through pangolin, but it is confusing, particularly as this virus undergoes a lot of recombination. It's also led to a lot of interesting figures. In terms of vaccination, this shows Australia alone. If you look at Australia, the vaccination rates are above Mexico, but certainly behind significant numbers of other countries in the world. But pleasingly, of course, the number of vaccines administered have increased significantly, particularly over the last 3 to 4 months. And we're now vaccinating large numbers of our population and large numbers of the risk groups. I'm not going to talk a lot about pregnant women. I understand that there will be more discussion about this, but it is important to point out that pregnant women are a priority for COVID-19 vaccination. The option of choice is the mRNA vaccines, either from Pfizer or from Moderna. And the reality is that the vaccine side effects in women are extremely low, and the benefits are extremely high in terms of things such as admission to hospital, admission to an ICU. The risk if a pregnant woman is unvaccinated is 5 times higher of admission to ICU than if they are vaccinated. And of course, the risk of invasive ventilation, which goes up something like 20 times. The other point is that the baby of that mother has a better outcome if the mother is vaccinated. We now have clear data about that. There are a large number of vaccine candidates. Of course, the Australian dialogue has really been about the Pfizer vaccine or the AstraZeneca vaccine, more recently about the Moderna vaccine. But there are over 300 RCTs in the world currently, and there are a small number in Australia recruiting for new vaccine trials. So I think what will happen over the next 12 months is we will continue to see new vaccine. The candidates are mostly protein subunit, that is just a part of the virus which has been separated in a similar way to influenza vaccines, although the details are quite different. The viral vector vaccines have been very important, in particular the mRNA vaccines such as the Pfizer and Moderna. So there are a number of other vaccines shown there, and we can discuss these. A lot of the vaccines from other countries, such as the candidate vaccines from Canada and China, have used a lot of different processes, such as inactivated virus, which is an old-fashioned but in fact quite effective vaccine candidate. The schedules for vaccines are different, and typically there are multiple doses, and typically they're based upon the spike protein shown in this schematic of the SARS-CoV virus, and it's obvious why you would base a vaccine on that. It's a highly immunogenic protein present on the surface of the virus. These are just some of the ones that you're very familiar with, the Pfizer and the AstraZeneca, more recently the Moderna and the Johnson & Johnson, Janssen and the Novavax. I've been asked to talk briefly about misconceptions. I'm happy to talk about that in questions, but just a couple of common ones in relation to pregnancy. The vaccine does not cause infertility. This was really based upon some similarities between the spike protein and a protein of pregnant women called syncytin-1, or a protein that's associated rather with fertility. And it does not. They're quite different. The vaccine does work against the Delta strain in preventing death and complications. The majority of patients in ICUs around Australia at the moment have received no vaccine or 1 dose. The vaccines don't contain traces, so the government can follow you around. If you sequence the virus as we do, you see no traces, and it just doesn't make sense. The question about it being a rush development, if you look at the vaccine trials of those we're currently using, they are the largest vaccine trials ever undertaken in the world. So finally, I'd just like to acknowledge everybody who works with us, and a couple of quotes from people that I think are quite relevant. Friedrich Schiller's comment that a merely fallen enemy rise again, but the reconciled one is truly vanquished, is interesting in that going forward, I believe that we will be living with SARS-CoV-2 and vaccinating on a yearly basis. And one of my heroes, Fred Sanger, who sadly died a couple of years ago, he famously was the recipient of 2 Nobel Prizes. He was someone who was very engaged in science. He was not a traditional translational scientist, and yet things like the genomic sequencing that he invented, so-called Sanger sequencing, is really the basis of so much of our public health work now. And I think it just indicates how important basic research is in how we proceed at a medical level, but also at a public health level. So thank you, and I'm happy to take questions during the question and answer session.
Thank you very much, Bill, for that fantastic talk. We're now going on to the talk that I think you all really want to hear about, and that is pregnancy, maternity, and the COVID vaccines. I'd really like to thank Jerry very much for joining us, and I'm so much looking forward to her talk. Thank you so much, Jerry.
Thank you, Jeff, for inviting me tonight regarding the interesting webinar and the timely one regarding COVID-19 vaccinations for pregnant patients, breastfeeding moms, and for women who are planning pregnancies. The COVID-19 has had profound effect on healthcare system, societal structures, and world economy. The adverse effects of COVID-19 pandemic on maternal and perinatal mortality and health are not limited to mortality and morbidity regarding the disease itself, but nationwide close downs, disruption of healthcare systems, and fear of attending healthcare facilities might also have affected the well-being of our pregnant patients and their babies. Public Health England released a statement on August 2021 that they had 130,000 deaths since December till now, within 28 days of COVID-19 being positive. And the most effective single way to protect the population is vaccination. The urgency and the manner in which COVID-19 vaccines were developed has put undue concern on our pregnant patients, women who are breastfeeding and planning pregnancies. And we need to acknowledge this, but there is plenty of safe data coming through regarding women who have had COVID-19 vaccines in pregnancy and not many adverse effects. I'm going to cover a few of my topics tonight regarding COVID-19 in pregnancy, the vaccinations recommended for pregnant patients, breastfeeding moms, and women who are planning pregnancies. And I hope by the end of the talk, we can provide you with enough reassurance regarding the increased protection of serious illness and hospitalization due to COVID-19. Women are more susceptible to infections during pregnancy due to the physiological changes that undergo their respiratory, cardiovascular, and their immune system. Most women who have contacted COVID-19 in pregnancy seem to have a mild disease. But recently in USA, 7% of their universal screening tested positive, and 75% of these were asymptomatic. It may come down that we may need to do universal screening for all our COVID screens for pregnant patients. Also, they do not present with the typical symptoms that we see in non-pregnant patients. 75% were asymptomatic and did not have fevers or myalgia, which then puts us in a difficult situation. How do we manage our pregnant patients? The reassuring thing is the death rate is 0.001 from COVID-19 in pregnancy. But there are certain serious illnesses that can happen when a woman is pregnant. She can go into preterm labor. She is 2 to 3 times at an increased risk of developing preeclampsia, eclampsia, and HELLP syndrome. She may be at an increased risk of needing cesarean sections, premature delivery, and 2 to 3 times increased risk of preterm birth. They did see a slight increase in stillbirth, but it is not statistically significant. There are fetal risks too. As a mother can go into preterm birth, she might have a preterm baby, and though the infections are not vertical transmission as so far noted, they could be at an increased risk of needing special care nurseries and stillbirth. The neonatal risk, 1 in 50 have tested positive with no disease, which indicates that it is low risk for neonates. 1 in 10,000 babies tested positive and was symptomatic. This is the data from 2020 British. 33% had severe illness, probably due to the prematurity. 50% was from contacts of family members after birth, and 12% was nosocomial. The Journal of Medicine from America Pediatrics recently did an inter-COVID multinational cohort study, which included 706 COVID patients and 1,400 non-COVID patients. And they found that there was a 2 to 3 times greater risk of preterm birth due to medical indications of delivering early due to preeclampsia, fetal distress, small for gestational age, and a small risk of stillbirth, which was doubled, although overall risk was small. The main thing is it does cause severe illness, especially if it is in the third trimester. There are certain risk factors which are associated with an increased risk of having COVID-19 in pregnancy: diabetes, blood pressure, asthma, age over 35, a BMI over 30, and being non-ethnic minor ethnicity groups. There was some research showing whether vitamin D deficiency had anything to do with this, and they were recommended that pregnant patients should take adequate vitamin D. Pregnancy and vaccinations. The college is aware and acknowledges the risk associated with COVID-19 for pregnant women. As such, they are now a priority group for COVID-19 vaccination and should routinely be offered one of the mRNA vaccine at any time in their pregnancy. Pregnant patients are at increased risk of having hospitalization 1 in 10 and developing severe illness, especially in the third trimester. Women are more prone to getting infections with Delta variant. So what are the vaccinations available in Australia for pregnant patients? We have the mRNA Pfizer and the Moderna, and the AstraZeneca, which is a vector vaccine. The mRNA vaccines have small amounts of genetic material known as messenger ribonucleic acid, or mRNA. It enters the cell cytoplasm, not the DNA, so it cannot change your makeup of your cells, and it produces a spike protein against the SARS virus. The vaccine is then quickly broken down within a few days, and the body goes on to produce antibodies to the spike protein and gives us immunity. The vector vaccines like AstraZeneca are a harmless virus that does not cause COVID-19, enters a cell and produces a spike protein, which is found on the surface of COVID-19 virus. Your body then recognizes the spike protein as foreign, and an immune system begins making antibodies, which our bodies store in case we come in contact with COVID-19. COVID-19 vaccinations in pregnancy. Most of the studies of the vaccines have been done in non-pregnant patients. Almost all the clinical trials are in non-pregnant patients. Data is mainly collected from overseas, like CDC, COPS, UCOX, and safety monitoring is done both in USA and UK via the vSafe registry monitoring by the CDC, Yellow Card, and MHRA in the UK, World Health Organization, European Medicine Agencies, Public Health England, Public Health Scotland, and ATAGI in Australia, which releases a weekly statement. What are the reassuring safety features for us regarding the COVID vaccine in pregnant patients? When the trials were going on, women who were recruited were advised not to have a pregnancy during the trial stage. They still had 57 accidental pregnancies, and so far, all of them are doing well, including their mothers and babies. To date, 55,000 pregnant patients have been vaccinated in the UK, and no adverse effects or serious concerns have been raised. 40,000 pregnant patients, which involved 6 studies in 4 countries, did not show an increase in miscarriage, stillbirths, small for gestational age, or preterm birth. 140,000 and over have been vaccinated in the UK. It's almost 23% of their pregnant patients have had the vaccine, and no unexpected pregnancy or infant outcomes have been observed related to the COVID-19 vaccine in pregnancy. A majority of the reports which they collected, 2/3 were related to local or systemic side effects, and to the pregnancy specific was miscarriages, but it was not substantially higher than what we see in a normal population. The vaccines were given in both first, second, and third trimester and involved all the 3 vaccines. The important thing to note is COVID-19 vaccines are not live viruses. They do not have any ingredients that could be harmful to a pregnant woman or her developing baby. The non-live vaccines have been used before too, like the flu vaccine and the whooping cough. Protective antibodies from the vaccinations do cross the placenta and may help the baby's immunity to COVID-19. The vaccine does not cause an increased risk of preterm birth, miscarriages, stillbirth, and small for gestational age or congenital abnormalities. No pregnant woman who had 2 jabs of the COVID-19 was hospitalized, and hence the recommendation from ATAGI and the Royal College of Australian and New Zealand. Research from across countries overseas has shown the safety of COVID-19 vaccine in pregnant patients. There are some side effects to vaccines, and not all vaccines and medicines would be safe, and there would be a certain group of our patients who will not be suitable to have the vaccine. And hence it's important to discuss case by case with the health professionals, obstetricians and GPs and midwives regarding whether they're suitable to have this vaccine or not. Majority of the mothers complained about pain at the local site of the injection or a systemic side effect like 1 or 2 days of flu-like symptoms. And they were no different to women who were not pregnant. 1 in 10 would complain about it. The serious side effects which were noted and rare were anaphylaxis, anaphylactoid reactions, allergic reactions, fevers lasting longer than 2 days, lymphadenitis, Guillain-Barré syndrome, menstrual symptoms of irregular bleeding, and the specific one called vaccine-induced thrombosis and thrombocytopenia, which is rare. And the VITT, out of 1 million doses given, 14 were detected to have that serious condition. When the second dose was given, it was 1.8 per million doses. Regarding the menstrual irregularities, out of 45 million doses given, 30,414 reported some menstrual irregularities, which seems to be not a significant amount, but women should report to their doctors, to their health professionals regarding this. And most of them were transient, did not need a blood transfusion, and it wasn't persisting. If it's in a post-menopausal woman, she might need further investigations regarding this. If people want any more details regarding these side effects, I'm happy to provide the paper, which was released by the MHRA on August 12, 2021. And these are figures from December till August, and it gives a detailed minimal side effects of these rare complications occurring. What are the side effects to the fetal and the neonate? Preterm birth, small for gestational, major congenital abnormalities were consistent with published rates in our rest of the population. Antibody transfer to the infant was noted in the cord blood and the breast milk, maybe giving some degree of protection to the newborn. Studies are still awaited. If a pregnant patient gets fever for more than 2 days over 38 with shivering and shaking, she needs to seek medical advice and take rest and take paracetamol. Pregnancy is not a high risk for these rare kind of complications, and there are no risk factors to determine who would develop VITT. But the recommendation is mainly for mRNA vaccine Pfizer in pregnancy, as most of our data is available for this vaccine in pregnant patients, and hence the recommendation from our official bodies. Breastfeeding is safe in breastfeeding mothers. Vaccination is safe in breastfeeding mothers, and there is no need to stop before, during, or after, and they should continue breastfeeding. And they can have any of the types of vaccine which are available and suitable for this age group of patients. What about then fertility and women who are planning pregnancy? There's been a lot of talk about COVID-19 vaccine causing problems for fertility. There are no documented evidence to suggest this. Plenty of statements have been released by the Fertility International Federation, European societies, and there is no document to say that it causes any fertility problems either in man or woman. There was no reduction in oocytes and there was no reduction in spermatogenesis. There were 340,000% increase in people looking at Google searches regarding fertility and the COVID-19 vaccine. And the fertility societies have all come out with the same recommendation that it is safe to have this vaccine and doesn't affect the fertility. There was a lot of talk about are women planning pregnancies during this pandemic. And some women were reluctant to even plan pregnancies, wanting to wait for the pandemic to settle down. Some have even opted to have egg preservation done as they're so worried about the pandemic. But there is no reason why these women cannot have this vaccine. Women who are having IVF treatment may need to discuss with their IVF specialist regarding what is the best time for them to have the vaccine. As sometimes if they're having a procedure like egg pickup or egg preservation, they might develop a small temperature and then we wouldn't know whether it's related to the vaccine or is it related to the procedure. So there might have to be an interval between having the vaccine and having their IVF treatment. If women who are on immunotherapy for IVF, they may not produce enough antibodies to give them the protection. Once again, important to discuss with your IVF specialist regarding what is the best time for you to have this vaccine. The recommendation from official groups is COVID vaccine reduces the risk of complications for both mother and baby. The Australian Technical Advisory Group on Immunization, ATAGI, and Rand Cox released a combined statement regarding the safety of COVID-19 vaccine at any time during pregnancy. The recommendation is 2 doses of Pfizer or Moderna vaccination provides good protection against COVID-19, including against the Delta strain. It is recommended to have 2 doses of vaccine 3 to 6 weeks apart. Having a vaccine definitely reduces the serious complications for both mother and baby. The vaccine can be given anytime in pregnancy, and there has been enough robust studies on almost 200,000 women across the world who have had the vaccine with no safety concerns. When they are also due to have their flu and whooping cough vaccine, they probably need to have a week's interval between this vaccination and the others. If they do develop some temperature, maybe a 14-day interval. The Pfizer is a recommended vaccine for pregnant patients, as most of our data is from the safety of Pfizer vaccine. It is recommended not to have both the vaccines of flu and COVID-19 or a whooping cough and COVID-19 on the same day. Women who have underlying conditions and who are concerned about vaccination should consult with their healthcare professionals for advice on their personal circumstances. Areas of research still to be explored are what is the best time for a woman to have her COVID-19 vaccine? What is the best gap between the first and the second dose? What are the long-term effects on babies born to women who have had COVID-19? And what is the outcome if we combine vaccinations? The recommendation at present is if a woman has had an AstraZeneca first, she should be, pre-pregnancy, she should be fine to have her second dose of AstraZeneca in pregnancy, provided she's had no side effects to the first dose of AstraZeneca. If they still have concerns, they need to discuss this with their obstetricians, their healthcare professionals, their GPs, and their midwives to see what is the best suitable one for them. Pregnant women should be counseled regarding the safety of these vaccines and come to an informed decision about the vaccination. Even after vaccination, it is recommended that pregnant women follow guidelines that prevent the spread of the disease. This includes universal precautions such as hand washing, social distancing, wearing a mask, and if symptomatic, undergoing testing and isolation. It is also recommended that partners and anyone in close contact with both pregnant women and newborn babies be vaccinated for COVID-19. Remember to seek medical advice if required. We encourage all pregnant patients to get vaccinated as the protection that it provides to both mother and baby outweigh the risk. The Delta variant is causing more pregnant patients to have severe illness than the previous strain of the virus. We hope that today's presentation has alleviated some of the concerns and reassured pregnant patients regarding the safety of COVID-19 vaccination based on the robust evidence from overseas studies of more than 200,000 women from US and UK with no safety concerns, and also safety for breastfeeding mothers and women who are planning pregnancies. Thank you.